So I'm Silipa, and so I'm presenting this audit on screening for Lynch syndrome in endometrial cancer that was done here in Auckland, and thank you for the opportunity to present this. So as we know, endometrial cancer is the most common gynecological cancer in developing countries, and New Zealand is no different in that there's an increase in new diagnoses. As you can see, with the increasing trend of numbers, there were 513 new cases in 2012 and now 686 in 2019. Lynch syndrome is found in about 2 to 5% of all endometrial cancers, and it is the sentinel cancer in 50% of the cases. And this gives patients with endometrial cancer the opportunity to get tested to prevent a second malignancy and to allow risk reduction strategies for their families if they're found to have Lynch. The median age for developing endometrial cancer in women with Lynch syndrome is around 49 versus 60 to 70 in the general population. And tumor testing for evidence for deficient DNA, MMR, or mismatch repair gene has been used to identify individuals at risk for this. Universal testing for Lynch syndrome in the endometrial tumors was first introduced here in January of 2017. It is a autosomal dominant inheritance and is associated with colonic and extracolonic cancers, which can also involve the uterus, ovary, urothelium, pancreas, biliary tract, stomach, brain, and potentially the breast. In patients with Lynch, the lifetime risk of getting colorectal cancer is somewhere between 52 to 82% versus 4% in the general population. And of getting endometrial cancer somewhere between 40 to 60% versus 10% in the general population. It accounts for about 3% of new diagnoses of both endometrial cancers and colorectal cancers. It's caused by a germline mutation in one of the DNA mismatch repair genes. The mismatch repair genes help maintain genomic stability and corrects for mismatches during the replication process. And so issues with the MMR will cause microsatellite instability that promotes cancer development. There are 4 genes identified, and that's MLH1, PMS2, MSH2, and MSH6. And their respective proteins have the function to recognize the DNA replication abnormalities which occur during meiosis and then perform an excision and repair. The mutation makes associated protein non-function and i.e. unable to correct the matching errors. And so this newly synthesized DNA strand is abnormally long, and the tumor is unstable, also called microsatellite unstable, and this causes inactivation of tumor suppressor genes and development of cancer. The MMR system recognizes base pair mismatches by the 2 heterodimer protein complexes, and it's MSH2 and MH6 form heterodimers, and MLH1 and PMS2 together. PMS2 only binds with MLH1, and as a result of loss of MLH1 function, this will automatically lead to a loss of PMS2 function or loss of staining, but the reverse isn't true. In terms of mutations that are most prevalent, mutations PMS2 are most prevalent in the population overall, followed by MSH6, MLH1, and MSH2. The aim of this was to assess the incidence of Lynch syndrome in patients who are newly diagnosed in our population, but also to assess the proportion of patients who accepted and underwent genetic testing. But also it was important to audit the change in practice during that time. And there were lessons learned during that time to achieve the process that we have now. And so now we have an algorithm for MMR testing and a algorithm for MMR result pathway for general gynecology as a result of the change in practice and the lessons learned during this process. This is the current algorithm for universal MMR testing on endometrial cancers for the Northern Midland Gynaecology tumor stream. And so all patients with endometrial cancer at diagnosis with an epithelial type of cancer, including endometrioid, serous, clear cell carcinosarc, or serous intraepithelial carcinoma, will have tumor MMR-IHC analysis to it. The MMR-IHC involves staining of the tissues for lack of expression, and this has roughly a sensitivity of about 83 and specificity about 90% respectively. This is more readily available and can be performed on small biopsies and is inexpensive and is done locally. If there is MLH1 and PMS2 loss, then hypermethylation of MLH1 is tested on the tumor, and this is done by PCR. And if hypermethylation is present, then this suggests a somatic abnormality as opposed to a germline. MLH1 hypermethylation accounts for majority of the MR deficient specimens in the screen population, and can be present in up to 85% of MMR deficient cases. In 2017, when this was initially started, testing for hypermethylation in Auckland involved sending the tumors to Peter Mac in Melbourne, and this meant significant delays. However, since 2018, this has been done locally. If patients have MMR proficient tumors, or if they have, and there's a high clinical suspicion for Lynch syndrome, then they still warrant a referral to the genetic services. And if they have MSH2, MSH6, or isolated PMS2 loss. In terms of the high clinical suspicion, this is defined by the Amsterdam criteria, i.e. significant family or personal history of endometrial cancer, colorectal cancer, upper GI, brain or bladder cancer under 40. And that warrants a referral regardless of the MMR result. So this was a retrospective study that looked at all consecutive women referred with a new diagnosis of endometrial cancer between the 1st of January 2017 to 31st of December 2018. And there was ethics approval then via HCheck, which deemed it low risk, and the data was extracted from electronic records and descriptive statistics were performed. The first 2 years, so there were new endometrial cancers of 409 patients, and the percentage of new endometrial cancers that were tested for MMR was 83%. This looked at the baseline characteristics of that group. So there were 409 new patients diagnosed with endometrial cancer within the Auckland region. The mean age was 60, which is about the average age for endometrial cancer. The mean BMI was 37, and 67% of the population had BMIs of over 30, with 1/3 of them having BMIs of over 40. Māori and Pacific made up majority of the ethnic distribution at about 42% versus 34% with New Zealand, European, and 10.8% with Asians. In terms of distributions between district health boards, about 35% came from counties, 34.5% from Auckland, and 28% from Waitemata. And 45% of these patients were operated on by non-gynecologists. And this is important as these patients, majority of these patients are being managed by referring general teams and being able to identify patients with high clinical risk factors, and referral to the genetic services would be important for this group. 74% of these patients had stage 1 disease with curable cancers with excellent prognoses. Histology, which was 79% with endometrioid, 9% serous, and 1.7% clear cell. This distribution is consistent with known literature. And in terms of the documentation of family or personal history, this was not well documented. And as you can see here, about 99% of patients did not have a family or personal history of malignancy that was documented that we could find. And about 5% of this population had a personal history of either bowel, breast, or renal bladder malignancy. And so this is an area for improvement for the long term. over the 2 years, so we had 409 new diagnoses of endometrial cancer, 339 patients underwent tumor MMR IHC, 271 had MMR proficient tumors, and 68 had MMR deficient tumors. However, within this MMR deficient population, 48 out of the 68 had a tumor MLH1 hypermethylation. And so this meant 71% of this was from a somatic genetic mutation. 16 had other MMR deficient tumors, and therefore 19 patients were eligible for genetic service referrals during this time frame. In total, this graph looks at the MMR deficient population, and so 68 with MMR deficient tumors, and as we said before, 48 had somatic tumors, and of these, 19 patients were eligible, and only 13 out of the 19 patients underwent germline testing. And from the 339 patients that were tested, 2.3% were diagnosed with Lynch. This is looking at the characteristics of patients identified with Lynch. There was a total of 8 patients, ages ranging from 38 to 62. 5 patients had a history suggestive of high risk of Lynch, which included being under 50 or had a family history of Lynch-related cancers. There was a 38-year-old who's patient 267 at the bottom who had a synchronous tumor with stage 1A grade 1 endometrioid and stage 1A clear cell adenocarcinoma of the ovary, who also had a family history of bowel cancer, and 3 others with family history of bowel cancer. So in this audit, 3 out of the 8 patients, so that was patient 20, 43, and 292, or 37.5% of these patients would not have the usual indicators that would have recommended Lynch screening as defined by the Bethesda criteria. And this is similar to a previous, to the 41% that was previously shown by Mills study back in 2014. So in this population, 2.3% had Lynch syndrome. This is comparable to known literature. 26% of the patients considered high risk for Lynch syndrome based on the universal screening did not proceed to genetic testing and counseling. And this suggests a need for improvement on uptake and assessment on barriers to genetic counseling and referrals. Now this looked at the timelines that are indicative of the patient's journey with MMR deficient proteins, and the median time range from MMR IHC or deficient loss to genetic clinic for germline testing results is about 9 to 10 months. So the median time from when a patient has a deficient immunohistochemistry to referral to genetics is about 17 working days. Time from referral to their first genetic clinic appointment is about 75 days. Median time from your first genetic clinic appointment to when the patient gets their germline blood testing is about 45 days. And the median time from getting that result to being seen to have a discussion about that result is about 38 days. And so this worked out to be the median time worked out to be 219 working days. And so this would be an opportunity to review our current timelines for improvement. This is the current guideline for the result pathway for MMR results as published by the Northern Midland Gynae Oncology Tumor Stream. And you can find this guideline if you Google endometrial and Hippo. And so essentially, MMR-IC testing is performed in all cases where there's a diagnosis, and the testing is done on the diagnostic sample at the DHB of residence, and the clinician looking after the patient is responsible for checking the MMR result in the path report. And if the patient needs methylation, there's usually a supplementary report that will be issued that can take a few weeks. And if the path report advises a referral to genetic services, then that needs to be done. And if the patient has a high clinical suspicion, then regardless of the MMR result or hypermethylation testing, the patient is referred to genetic services. The limitations of this was it was initially a prospective design and end up being a retrospective data collection, and it's limited by the information on the database and availability of electronic medical records. The lessons learned during this process was the need for education of implication of a change in practice to all stakeholders, and a review of the processes and creation of a ratified guideline for the process that included liaising with primary referring gynecologists, labs, pathologists, and genetics team. In 2017, there were significant delays to the hypermethylation testing, but this has now been rectified by having this done locally. And currently, germline mutation testing specimens are sent to Peter Mac in Australia. So in conclusion, the prevalence was still 2.3% of Lynch syndrome, which is comparable to other studies. 37.5% of patients were identified using universal testing, and these patients would not have been identified otherwise. Having said that, 26% of these patients that were eligible, and so that was 5 out of 19, declined either genetic referral, or if they were seen, declined testing. During practice change, the learning process and strategies need to be put in place before a change in practice, and we could repeat this on our current practice. Thank you.
You sound so full of joy, Silipa. Thank you for your presentation. Any questions from the floor? So I've got questions to patients who deal with endometrial, doctors who deal with endometrial cancer every day here. When you do an AUB clinic and you get your report, is the methylation now on the same report?
I think so. Not sure. I know it's supplementary.
Yeah, so
that's a supplementary.
So you have a system to basically check your report, right?
I think it comes back if there is a supplementary report issued. I think it comes back. It comes
to your clinician
as a sign off in your inbox again. Like when you look through it, I think once you right, make it is potentially an error.
Because we had it was raised at a meeting probably a year ago about who's responsible and how to get to us the supplementary. So I'm not sure what the upshot of that was.
Okay.
I think Lois went back to the lab and
told them that they needed to resend to the person who signed off whose name the cure things were under.
But I don't know. I haven't actually had one.
No.
So there's I'm sure.
Yeah, but that's why we want to repeat the audit, because basically one of the things identified was that the pathologists were not doing the MMR immunohisto to everybody.
Yeah.
And then there was a bit of no referral that was not happening. So if you drop a few at each stage, then basically the findings are not as good as you could.
Yeah. No, that's a good point.
Yeah. So Silipa, sorry, what that 26% of non-compliance, can you just go back and what that was? Is that where the test doesn't get asked for, or
I'll take you back here.
So
it's not so it's this here. So so it's basically these patients here who were either offered, who had a MMR deficiency, who were offered referral to genetics, but then declined it. So you have 1 here, 2 here. All the other one is they were seen at genetics clinic, but declined testing.
Right.
And so that's that.
Okay. Do you have any idea how that could be improved?
For this year, for the ones who've already gone through genetic testing, they're the ones who obviously who've made informed decisions. I just wasn't sure how much we were stressing it from a referral point of view, because that we can influence.
Yeah,
Yeah, I think it's a lot. The problem is the packaging of the information is very
Yeah.
concentrated. So we end up telling them, oh, you've got cancer in an operation. They're completely stressed. They can't hear
Yeah,
anything
it's
about
less than
that.
they get.
And then you say, oh, you're fine. You don't need anything else. You've got a 1A grade 1. And suddenly it's like a souffle. The whole thing is like, okay, I'm done.
Mm.
Goodbye. And then there's a short window of interest where you say, hey, wait, we found
Mm.
something else. And I do find that whether it's that or the BRCA for the ovaries, it's the same sort of thing. It's how you package it to say, yeah, there's another thing about your health, and it
Yeah.
almost warrants another consult.
Yeah.
Yeah, I think I have to say it's probably true that you wouldn't want to just explain it on
Yeah.
the phone quickly, you know,
Yeah.
like, and often I think if you see them face to face, you can probably get that information better.
I
across,
had a
you know.
lady who actually declined initially when she was diagnosed, but 2 years later, she actually interested.
Yeah.
So
Okay.
after her husband was actually diagnosed with
But
bowel cancer.
But the other thing I was thinking is written information, because we actually don't tell them. We even if we tell them is we don't have a leaflet that
Yeah.
says you've been screened and there is a small chance that you are actually carrying a mutation that puts you at risk of other cancers. This is what we would like you to do, and you've been referred to genetics for this reason. And we could, I think that might be a
That
think
might
it's a
be,
good
yeah,
idea.
that's a really good idea.
But I think it'd be good if you have a face-to-face appointment with some
Yeah.
written information, and then
Yeah.
they come to genetics a lot better
Yeah,
prepared.
yeah,
Because they probably decline because we didn't prepare them,
Yeah,
that's what I
yeah,
think, you know,
yeah.
because if they came that we think it's a good idea, I think a lot more people probably would take
Yeah.
it on because they trust you and they know you sort of thing.
because I mean, 50% of these will end up having a bowel cancer, which is entirely preventable.
Compared
So
to
even
4%.
But even
Yeah.
for their family as
Yeah,
well, you
yeah,
know,
yeah,
you know.